This conference will now be recorded.
Okay, am I audible? Good afternoon, everybody. Am I audible?
Good afternoon, sir. Yes, sir.
Okay, fine. Today we'll be discussing a small topic in ocular trauma or closed globe injuries. I believe ocular trauma, the topic has already started. In that, we will be discussing about closed globe injuries. Here, in this particular topic, trauma, when a blunt trauma occurs to the eye or when there is a trauma to the eye globe is intact, but the internal structures of the eye are damaged. So that is why this topic is been differentiated from other topics, and the name is given closed globe injuries. Means the injuries are occurring within the structure of the eye, but the outer coat of the eyeball is intact. So what are the various problems or what are the various types of closed globe injuries which can occur? Now coming to the topic, what are the various modes? In general, what are the various modes of injury to the eye? There can be a direct blow, or there can be an accidental blunt trauma, there can be a closed globe injury, or there can be an open injury. Open injury means it could be either a penetrating trauma or a perforating trauma. Penetrating trauma means it has an anterior opening or entry point is there, but if the eye globe has both entry point and the exit point, means there is an entry from the anterior side. Let's take an example. There is an entry wound from the anterior side and the exit wound from the posterior side of the eyeball. There is an entry and exit, then it is called perforating wound. So the terms should be clear: penetrating injury, perforating injury. Perforating means from through and through, it has completely gone through the eyeball and exited out of the eyeball, the injury. And penetrating is it has only an entry wound, but exit wound is not there. So that is penetrating injury. So now closed globe, the eyeball is intact, and open injuries, as I said, could be penetrating or perforating. Contusion and rupture. Contusion is just a blunt type of trauma where the eyeball is intact. Rupture, the eyeball opens up. Laceration also is similar, and lamellar laceration, depending on the level of extent of injury or level of extent of the trauma or the tear, you put under various headings. So all these are various modes of injuries which can occur to the eyeball or which can happen to the eyeball. So other modes of injuries which are incised injuries, penetrating injury, perforating injury, these are all other modes. Basically there is an injury to the eyeball. Incised injury is mostly a surgical injury. Penetrating, as I said, entry wound is present. Perforating, as I said, there is an entry wound and then exit wound. So now injury can be broadly classified into two types: open globe and closed globe. It is the effect of injury on the eyeball. It can be closed globe injury or it could be open globe injury. So closed globe, the causes are your contusion and lamellar laceration. And open globe, there can be complete laceration or there can be a rupture. In laceration, there are further types like penetrating, intraocular, foreign body, or perforating injury. And other type of injury is rupture, the effect of injury on the eye which can be rupture. So basically, when the globe is intact, when complete globe is intact, then you call it as closed globe injuries. When the globe opens up, or the eyeball opens up due to the injury, it is called as lacerate. It is called as open globe injuries. The causes, there are various types in that: rupture and laceration. Laceration can further be classified into three types, that like penetrating, intraocular, foreign body injury, means something has penetrated into the eyeball and stayed there, and perforating injury, which has entered into the eyeball and exited also through the eyeball. Now, what are the injuries which can occur in the eyeball, or what can happen at each level at various anatomical structure? What are the types of injuries which are commonly seen? So the lesions seen in closed globe injuries, we classify them as per the structure. So for example, we'll start from anterior and then go towards the posterior side. In the anterior side, we have cornea. That is, what can happen on cornea? There can be aberrations. Aberrations means it is just something like a scratch on the cornea. There is a the epithelial layer is affected due to some injury. There is a defect in the epithelial layer of the cornea, and which there can be some corneal edema, swelling of the cornea, or there can be tears in the Descemet's membrane. Basically, the various layers of the cornea are affected. If it is at the epithelial level, then you call it as aberration. This is the possible outcome of a closed injury. Because of the injury, there can be aberrations, and there can be corneal edema. There can be swelling of the cornea, which can and be due to secondary due to the closed globe injury. The cornea becomes thick. When you see in a slit lamp, the thickness of the cornea appears to be increased. You will see a lot of striate keratopathy, or you will see some tears in the Descemet's membrane. All the anterior layers of the cornea, sparing the endothelium, there can be effect on the cornea. So these are the various types of effect on the cornea. Then hyphema. Hyphema is nothing but it is a finding which is seen in the anterior chamber of the eye. Within the what is anterior chamber? It is the space between the iris and the cornea. That space is called as anterior chamber. In front of the iris and posteriorly, from the posterior border of the cornea to the angle and the anterior surface of the iris. The space between that is called as anterior chamber. And when there is a blood in the anterior chamber, it is called as hyphema. So what is hypopaeon? For example, let's take another example called hypopaeon. Hypopaeon is nothing but when there is a pus in the anterior chamber. So then when there is a blood in the anterior chamber, or whether there is hemorrhage in the anterior chamber, then it is called as hyphema. So sources of bleeding in is iris or ciliary body. So the bleeding sources can be from the vessels which are along the iris or in the ciliary body. Now, what is the problem with this hyphema, and what is the problem with this corneal edema? Corneal edema usually resolves over a period of time, but if there is a Descemet's tear which is very severe, it can damage the epithelial integrity, and cornea can become opaque, and then patient can have a loss of vision due to that. So if edema is just at the level of corneal epithelium, that is corneal abrasion, you just patch the eye, it will improve over a period of 124 to 48 hours. But when there is corneal edema, you have to reduce the corneal edema by giving hypertonic saline and giving some steroid drops, so that the inflammation subsides and corneal edema slowly resolves. But if there is a tear in the Descemet's membrane, based on the amount of tear in the Descemet's membrane will decide the corneal integrity. If the corneal integrity tears, if the Descemet's membrane tear is is too much, when you examine, that much part of the area will be filled with edema, and the resolution of that edema will be very slow unless you reattach the Descemet's membrane surgically, or by implanting air in the anterior chamber. You have to push the Descemet's membrane to the cornea so that the integrity is maintained. Then the cornea edema improves. So corneal edema is not just a simple problem. It has to be dealt with accordingly based on the etiology, whether it is epithelial edema, or it is involving the stroma, or whether it is involving the Descemet's membrane, and so on. So when it comes to hyphema, as I said, it is blood in the anterior chamber. So what happens if there is blood in the anterior chamber? It can increase the pressure of the eye. It depends on the extent of the blood in the anterior chamber. If the blood in the anterior chamber is less than 1/3, usually it gets absorbed. But if the blood in the anterior chamber is more than half, you have to observe the eye for signs of raised intraocular pressure. If it is if it does not resolve within 3 days or 5 days and the intraocular pressure is high, then you have to actively intervene and remove the blood from the anterior chamber. Otherwise, what is the problem? The problem is that the blood will stick to the endothelium. So what is there in the blood? There are RBCs, and these RBCs get degraded, and then these degraded RBCs, the hemosiderin pigments which are there in the RBCs, they will go and stick onto the endothelium. So what will happen if these go and stick to the endothelium of the cornea? They will cause haziness in the cornea and the vision will drop. So ideally the blood has to be removed from the anterior chamber if it does not get absorbed on its own within a period of 3 days, and there is an if the IOP is not under control or if IOP is increasing. So these are the problems. So that is why we have to first identify the anterior segment. What is the problem in cornea? Corneal edema has to be treated appropriately and hyphema has to be treated appropriately. Now coming to the sclera. What happens in sclera? There can be a partial thickness scleral wound which can be sutured. So if there is a full thickness scleral wound, that means it becomes an open globe injury. It is not called closed globe injury. Some amount of sclera is left, means eyeball coat is intact. Now coming to anterior chamber, what can happen? As I said, traumatic hyphema can occur or traumatic uveitis can occur. Now to hyphema, I have already discussed what are the problems which can be seen. And uveitis, what is uveitis? Uveitis is inflammation of the uveal tissue. Why there is inflammation of uveal tissue? When there is an injury, the uveal tissue gets inflamed. Now what is this uveal tissue? It includes 3 parts: iris, ciliary body and choroid. So this, when it inflames, it can lead to iridocyclitis or it can lead to choroiditis or various intermediate uveitis, various causes or various problems it can lead to. But most common is the iridocyclitis, which we commonly come across. So how do you treat this uveitis? Obviously, whenever there is an inflammation, you have to give steroids to suppress the inflammation. And since there will be a lot of pain associated with uveitis, we have to give cycloplegics, which will reduce the pain and relax the ciliary body. So the best cycloplegic is atropine. So atropine, steroids, analgesics is the mode of management of traumatic uveitis. And definitely you have to add anti-glaucoma medications, because when there is blood in the anterior chamber, it can also give rise to rise in intraocular pressure. So IOP has to be controlled, inflammation has to be controlled, and ciliary body has to be paralyzed. So that is the main mode of management of a case of closed globe injuries. Now coming to iris, pupil and ciliary body. Now we'll go to the individual structures. We have seen cornea, we have seen anterior chamber, what can happen, and then we'll go to iris, pupil and ciliary body, that is the middle part of the globe. So what can happen in iris? There are possibilities of traumatic miosis. Traumatic miosis means normally the pupil size is around 3 millimeters. Because of trauma, the sphincters start to constrict further and it leads to miosis. So the size becomes very small because of the insult to the globe. The iris overreacts and there can be miosis. Sometimes what happens, there can be sphincter tear. The sphincter muscles can tear and it can lead to mydriasis, means pupil becomes bigger in size. It becomes 5 mm in size, or there is rupture of the pupillary margins, or there can be iridodialysis. Iridodialysis means detachment of the iris from its insertion from its point where it starts from ciliary body. So that point the iris can get detached. So what will it lead to? It will lead to a D-shaped pupil, and there can be inflammatory changes like traumatic iridocyclitis, hemophthalmitis, post-traumatic iris atrophy, or pigmentary changes. Pigmentary changes means because of the injury, the iris pigments will get dispersed and get stuck onto the endothelium and the lens. So these are the some common changes which we come across in iris, pupil, and ciliary body. Either there is meiosis, that is constriction of pupil, or there is mydriasis, pupil fully dilates. It could be primary or it could be secondary due to sphincter tear. Sphincter tear means this pupillary constriction is caused by sphincter muscle and dilatation is caused by dilator muscle. When there is trauma, there is a tear to the sphincter muscles which can lead to rupture of the sphincter muscles, or the pupillary margins get broken up. So when they are broken up, the pupil constriction is affected, so pupil appears to be dilated. So these are some telltale signs which are seen commonly when you examine a patient who has trauma. So what is the management? Management is mostly by steroids, atropine, and antibiotics. Antibiotics to control infection, steroids to control inflammation, and atropine to paralyze the ciliary body to reduce the pain. This is the standard mode of management. Another one which needs to be added here is anti-glaucoma medications to control the intraocular pressure. Now, what can happen to the lens? If you see in this picture, there is a cataract in the lens. You can see it is a in the shape of a flower. So it is sometimes also called as rosette cataract or when you see such type of cataract in a patient, it is called as traumatic cataract or rosette cataract because it appears like a petals of the rose flower. So this traumatic cataract is one common complication which can occur in the lens of the patient. Now, what is this osseous ring? Osseous ring is nothing but, now if you see in this particular patient, the pupil is dilated here. When the pupil is constricted because of the closed globe injuries, this iris pigments which are present behind the iris, or this iris will go and hit the lens, or it will just touch the lens, or this pigments will just go and touch the lens. So what will happen because of that? It will form an impression, round impression on the lens. There will be a round brown ring on the lens in the form of dots in this particular area when the pupil is constricted. This traumatic cataract usually develops after a period of time. Sometimes it can take hours, sometimes it can take years. So but definitely a history of trauma will definitely be present. So osseous ring is nothing but pigment deposition on the lens in a circular fashion because of the impression of the iris which is forming on the lens. And traumatic cataract is a lens change which occurs due to closed globe injuries. Other common varieties of traumatic cataract which are commonly seen is, one is posterior subcapsular opacification resulting in flower shaped opacities. So you can see here posterior subcapsular, this is the anterior capsule of the lens. Posterior subcapsular, when you see on the slit lamp, you will see sometimes an opacity on the posterior surface of the lens. So that is also one form of cataract which is commonly seen in closed globe injuries. And next one is subluxation. This lens is usually attached with zonules to the ciliary body. And if you see here, you can see the edge of the lens because the zonules have got detached. So there is, but completely lens is not absent in the pupil. You can see a part of the lens in the pupil. So that is why it is called as subluxation. So subluxation of lens, when you see a part of the lens in the pupillary area, means lens is not fully displaced from pupillary area, then you call it as subluxation. If the lens is completely moved out of pupillary area, then you call it as dislocation. From its location, it has moved out somewhere else. It can be into the vitreous, it can be into the ciliary body, it can be into the anterior chamber, or anywhere. It has moved, but it is not in the pupillary zone. So these are some of the possibilities or some of the changes which can occur in the lens: traumatic cataract, subluxation, dislocation, osseous ring formation on the lens. These are some of the changes which are commonly seen in closed globe injuries. Now coming to posterior segment problems. Posterior segment means what can happen in the vitreous, what can happen in the retina. In the retina, we come across these changes. First one is commotio retinae. Second one, choroidal rupture and hemorrhage. Third one, avulsion of vitreous base and retinal dialysis, equatorial tears, macular hole, optic neuropathy, vitreous hemorrhage. So these are some of the changes which are seen in posterior segment. Now what are these? Each of these will go in detail. So what is here? You are seeing here commotio retinae. Commotio retinae means mainly the central part of the retina is edematous. Okay, so when that central bit is sometimes called as Berlin's edema also, this central part becomes pale. You see a whitish region here. So this central part becomes pale. So this is commotio retinae. Now if you see in the second picture, there is an arc here. You can see this arc is nothing but it indicates that, and you can see the blood vessels running above the arc. Now this is the optic disc. These are the vessels, and this area is the macula, and you can see the blood vessels are running above the arc. So that means the lesion is pretty deep and there are hemorrhages around the lesion. That means there is a rupture of the choroid. So our eyeball has three coats. One is retinal coat, then next is uveal coat, or posteriorly it is called as choroid, and then the scleral coat. When there is a rupture, choroidal rupture, you see this type of picture. Okay, now this is retinal dialysis. The retina is usually, so you can see here, this is the disc. Okay, this same disc, if you extend the picture and go more towards periphery, the retina extends from the center till the periphery till the ora serrata region. Here this is the ciliary body, pars plicator region, and what you see here is the attachment of the retina near the ora serrata region. So this is the ending point of the retina. Retinal dialysis means the retina gets detached from its attachment near the periphery. So there is avulsion of vitreous base and retinal dialysis. The vitreous pulls the retina towards the center due to traction. So the retina gets detached near the periphery. So this is an example of retinal dialysis. Like we saw in the previous slide, like iridodialysis, where the iris gets detached from its attachment to the ciliary body. That is an iridodialysis. Here it is the retinal dialysis. Now this is an example of retinal detachment, and the retina gets detached, and there are because of the equatorial tears. And this is an example of macular hole. Now this is the optic disc. These are the vessels up and below, and there is a hole formation in the macula. On long-standing cases, you come across this particular type of problem. The macula, it develops holes because there is a traction of the vitreous in the either direction, up or down, horizontal, vertical, or tangential traction, and it pulls the retina peripherally towards the periphery, and centrally hole develops. So this is the last one is the optic neuropathy. Because of trauma, the optic nerve gets damaged due to shearing stress, or there is a stretching of the optic nerve sometimes, which can damage the optic nerve fibers. So over a period of time, what happens? It leads to traumatic optic neuropathy. The disc becomes completely pale and the patient loses his vision because of the damage to the disc. The disc appears round, but it has lost its nerve fiber layer sheen. The color, the orange sheen, it has lost. So this is an example of traumatic optic neuropathy. So these are the posterior segment findings which we come across in a case of closed globe injuries. For all these conditions, choroidal ruptures, retinal dialysis probably we can treat. We can treat the retina. We can attach the retina back, but the prognosis is very poor. the chances of improvement of vision are very less. The damage is anterior. In the anterior segment, to some extent we can manage, but if the damage is in the posterior, the chances of improvement of visual acuity is poor. The chances of the good visual prognosis chances are very poor. Coming to vitreous, what happens in vitreous? Vitreous, there can be blood. When the vitreous is filled with blood, it is called as vitreous hemorrhage. Commotio retinae is another. Just now I showed this picture. This is an example of commotio retinae. What happens is it's also called as Berlin's edema, caused by concussion injury of the retinal, resulting in cloudy swelling, which gives involved area a gray appearance, or sometimes you can also see a cherry red spot, few intraretinal hemorrhages. Usually this edema resolves within a period of 6 weeks, and sometimes it can lead to pigmentary degeneration and macular hole formation. This can progress to this stage, macular hole formation, because of the traction in the vitreous. This optic nerve I have already discussed. Traumatic optic neuropathy, it usually presents following ocular, orbital or head trauma as sudden vision loss. Vision is very poor from the onset, while onset with only PL positive, that is perception of light. Only objective finding is afferent pupillary defect. The retina, in the retina, when you examine the retina in a case of traumatic optic neuropathy, the disc is completely pale. It becomes completely white like this. So that means the optic nerve is completely damaged. So the visual acuity will obviously be affected. All the optic nerve function tests are also gone. So this is an effect of closed globe injury on the optic nerve. Spontaneous visual improvement usually occurs in up to half of indirect injuries patients. Steroids intravenously and optic nerve decompression can be tried. Whenever the patient has optic nerve injury, usually prognosis is 50-50. But what is tried is in giving intravenous methylprednisolone is tried. When you give intravenous steroid, for some patient it is effective, but majority of the patients usually the prognosis is poor. And you can also try one more surgical option, that is optic nerve decompression whenever there is an edema of the optic nerve in case of traumatic optic neuropathy. Now, to remember all these, what are the effects of injury, closed globe injury on the eye? You can remember them in the form of circles. The first one, or the first circle, is the iris sphincter. So iris sphincter is a round circle near the pupil. So it causes constriction of the pupil. So when there is a tear in the iris sphincter, it can cause traumatic mydriasis. So that is one point. Second one, you move from the iris towards the periphery near the ciliary body. It forms another circle near the insertion of the iris forms another circle. So what can happen there? There can be iridodialysis. From there, you proceed to the ciliary body. This ciliary body can get detached from the its attachment near the sclera. So it is called as cyclodialysis, or there can be an increased gap between the iris and the ciliary body. So that is called as angle recession, or there can be a trabeculodialysis or trabecular meshwork damage. So the next one is ciliary body can get detached from the scleral spur or the sclera, that is called as cyclodialysis. These are all in the form of circles. You start pupillary circle, then go towards the periphery, you will have the iris circle, the attachment of the iris near the ciliary body, and the ciliary, then angle forms one circle, and then the ciliary body forms one circle. So each circle, if you remember, then you will be able to remember what are the effects of closed globe injury on the eye. Next circle is formed by zonules, where it is attached to the lens. Zonules, when they are detached, it leads to either subluxation or dislocation of the lens. The next circle behind the zonules is the ora serrata, where the retina is attached. When the retina gets detached, there can be retinal dialysis. So if you remember various circles, you will remember the 6 main findings of a closed globe injury. So these are some highlights of closed globe injury. It can be a short note question for you, and extreme details are not required. You have to remember what are the main effects of closed globe injury on the eye. If you remember the anatomy of the eye in the form of circles, then one by one you will be able to identify the changes which occur at each level, at the level of iris sphincter in pupil, at the level of iris periphery, at the level of ciliary body, at the level of attachment of ciliary body, at the level of zonules, and at the level of attachment of retina to the ora serrata, or the retinal dialysis or detachment. So these are some of the main manifestations of closed globe injury. When it comes to anterior segment, the main management is steroids, antibiotics, and cycloplegics. When it comes to posterior segment, you have to treat according to the type of presentation. Usually, if the posterior segment manifestations are present, it will definitely affect the visual acuity depending on the extent of damage it has caused to the posterior segment. So these are some of the highlights of closed globe injury. Please read your textbook to understand it better. If you have any clarifications, you can always revert back. Thank you.